Hello everyone, this is Chadi from CVI 2023. I'm really privileged to be with Dr. Jonathan Schwartz. Today we're going to talk about the tricuspid valve. This is a new kind of big push for the majority of the valves now, and then this is kind of the up-and-coming valve. Triluminate, presented in 2023 ACC, and it has its good findings and also some controversial issues. So let's walk through that.
For sure. Well, thank you. It's always a pleasure to be here at CVI. I think we always get to meet up here, which is great. We're in a new venue this year in Austin, so we always try to be a little innovative, which is good.
So yes, warmer.
A little bit warmer, a little warmer than usual. I think for Austin even. But yes, so great points. It's sort of interesting. I think we've sort of, I wouldn't say we've conquered, but the aortic space has really been flushed out well now. TAVR is very well established. Still have some work maybe with AI to do, but the aortic stenosis is pretty well established. We moved on to mitral. That's been a lot slower than I think we expected for a lot of reasons, which we could maybe talk about at one of our future meetings here. But tricuspid, actually, we're getting results a little bit faster than we probably expected. And I think a big part of that has been there just isn't really any good therapies. We've been stuck with medical therapy for a long time. We call it the forgotten valve. I kind of like to say it's more like the neglected valve because we've known about TR. We just didn't have much to do for it. We've been putting pacemakers in all the time, leaving patients with TR and just sort of hoping for the best, which is, we're learning now that probably wasn't the best decision.
Absolutely.
So Triluminate, the first randomized trial looking at transcatheter intervention on the tricuspid valve, which has been great. Our center was lucky to be in the trial, and we were one of the top enrollers, which was also very nice. And Dr. Sraja was the PI who runs CVI, so very focused on the tricuspid valve at this meeting. Very good results from a safety perspective. The procedure is very safe. The mortality rates were very low, much lower than with surgical tricuspid valve intervention. And the quality of life benefit was very clear. It outdid any expectations that they had in terms of benefits. So that was really good to see as well. There have been some criticisms, particularly on Twitter, as usual. A lot of naysayers, and maybe I think people were sort of maybe hoping for either a mortality benefit or potentially rehospitalization benefit, which it didn't show. But there's a couple of reasons for that. I think, number one, it wasn't totally focused on that. The FDA asked them to have those as outcomes.
As a standard.
And it makes sense, and almost every trial has that, but also, this is the pivotal trial, but it's only the first half of the enrollees, so only 350 of the total 700 patients that were enrolled were presented at ACC, so there will be more data, which is great. It is only 1 year follow-up, and so expecting to see a mortality benefit at 1 year with tricuspid valve disease is just not practical. I mean, we all know patients live with TR for years. It's not like aortic stenosis, it's not like heart failure with mitral regurgitation. It's a different disease. The RV is a lot more malleable and able to sort of tolerate this for a lot longer. So I think sort of resetting the expectations is important, that we shouldn't really have expected that. It makes sense that people were after COAPT was presented, and COAPT showed amazing results. And so I think everyone just sort of said, oh, we anticipate it'll be the same, it's going to be great, we'll get it approved right away and things will move.
But LV is completely different beast.
Completely different. We're not quite there. We need more data. It's coming. An interesting aspect of Triluminate is a certain subset of patients within the trial are in what they call the imaging sub-study. And so they all got both a CT and an MRI before the procedure and after. That data is not available yet. There's a chance it's going to be presented at TCT this year.
Is it focusing on function or?
Everything. So function, regurgitation, RV size, the outcomes in terms of like mortality, all that, it's all the same as the Triluminate study. It's strictly just looking at the imaging studies pre and post.
Which is important information too.
Yes, exactly. So I think we're going to learn a lot from that as well. The FDA submission, I think, is coming later this year, and so we'll just have to see what happens with that.
So question, don't you think the timing of repairing the valve before the RV give up is important aspect during the implantation?
Incredibly, and you're hitting on a great point there. And so that was not standardized in the trial at all. So some patients were coming in showing signs of severe TR, but maybe they didn't really have many symptoms. The RV was preserved. They still got enrolled and the TR went down, but of course if you have someone who doesn't have a lot of symptoms coming in, they're not going to show as big of a jump afterwards. They weren't getting hospitalized before, so how do you show a benefit there? So I think that's another thing to learn. This is just the first step into that process, and almost certain future trials will probably be a little more protocolized with how far along in the disease process they are.
And also, you can argue, like if you implant the reparative valve in an RV that's still preserved, you're helping this RV to fail in 2-3 years down the line.
Exactly.
So we don't know this data as well yet.
Completely. And also an interesting sort of wrinkle in all this is soon the TriSend results are probably going to come out. It's done enrolling, so that's the Evoke transcatheter valve replacement. So we'll see if there's any differences. I mean, it makes sense that there might be, but no one knows yet.
Yeah. Is this valve suture based, or how is it?
Yeah, so it's not suture based. It's transcatheter delivered through the leg. It's got these little arms that's actually the hardest part of the procedure, is making sure that the leaflets are inserted in the proper spot between the valve structure and the little arms to hold it in place.
And then you can click it to replace the whole valve.
Exactly.
Wow.
But despite as complex as the design is, it really only takes about 2 hours or so to do the procedure. So it is, I think, potentially a feasible option in the future.
That was great. Okay, Jonathan, always nice to talk about this with you in general, but this topic is very important.
Always.
And I think this is a hot topic coming up for any structural meeting. Thank you for your time, and thanks everybody for watching. This is CVI 2023 from Austin. Jonathan, thank you so much.
Thank you.